Hi everyone, welcome to today's talking point presentation. I'd like to begin by acknowledging the traditional owners of the lands on which we meet, for us here as the Wurundjeri people of the Kulin Nation, and pay my respects to their elders past, present and emerging. I extend that respect to Aboriginal and Torres Strait Islander people who may be listening today or in the future. My name's Shalini Arunagiri. I'm Clinical Director of Turning Point Statewide Services in the Hamilton Centre and Associate Professor at Monash University. It's my pleasure today to be facilitating our talking point session on addressing underlying trauma and opioid use, presented by Dr. Tanya Saraiya. Talking Points are a regular series of publicly available lectures that aim to inspire, inform, and challenge our notions of what we know about addiction and its impact across society. We'd like our webinars to be as interactive as possible, so please ask questions via the Q&A function for online attendees. We also today have some attendees in the room who will also be able to ask some questions at the end of the session. The questions will be collated and answered by Tanya at the end of our presentation today. Our webinars are recorded and are later made available to view on our Turning Point website. So I'd like to introduce our presenter, Dr. Tanya Saraiya, PhD, who is an assistant professor, licensed clinical psychologist, and director of the PATH Lab in the Department of Psychiatry at the Medical University of South Carolina. Broadly, her research aims to understand and attend to traumatic stress and PTSD in individuals in recovery for substance use. Across her work, she strives to focus on health disparities and ongoing inequities that present based on individual and collective identity, culture, race, and context. Welcome, Tanya.
Thank you so much for the introduction and having me here today. So this is our lab that I get to direct. It's called the Pursuing Addiction and Trauma Healing Lab. We love acronyms in the US, so everything has an acronym. And I'm Tanya. Okay, so first I'd like to start with some acknowledgements. These are all the people that make this work happen. Their colleagues and mentors on the screen, students and graduate assistants, some of us that went to CPDD, and then of course my husband, who's come all the way to Australia with me since I'm pregnant. He didn't want to make me go alone. He also came for Australia as well. Okay, so a little bit about the outline for today. So I'm going to first talk about how did I get here, because I'm probably a new face for most of you, so you're curious who I am. The passion, which is trauma and opioid use, the intervention we've developed called HOPE, the issue, which is diagnostic issues in trauma and PTSD, the toolkit we're developing, and then where are we going next. So I'm going to actually take you way back. So these are my parents on their wedding day. They had an arranged marriage in India, which is very common. They only knew each other for 2 weeks, and they grew up in lots of poverty, but had aspiring dreams to overcome that trauma and poverty. So they immigrated from the United States, first to the UK, which my father did not like as much. And so then he went to America, sorry if you're from the UK. And then he eventually landed in Tampa, Florida, which is that southern state in the United States, which is very low. And that's where I grew up and where I was raised. And I say all of this to give you a sense of kind of the lens that I come from. So my sister and I growing up were very cognizant that we were immigrants. We were immigrant children in the United States. And so we were always aware of language barriers, identity, and who we were and how that related to the US context. And so that is really what stemmed my interest in trauma from such a young age. But when I went to graduate school, I noticed that we often were not attending to trauma, that we would tend to focus on the limbs of this tree, so anxiety, substance use, depression, autoimmune diseases, but that underneath all of that was trauma, and that few people were talking about it, addressing it, or attending to it with their clients. What's more is that we even ignored intergenerational trauma, so stories and experiences that reverberated through cultures or ancestors that people were presenting with today, but that we didn't have the language within graduate school or graduate training to really talk about or address. So in my academic journey, I left Tampa, Florida, which is very sunny and warm, and I went to cold New York. And in New York, I worked with Denise Yan, if any of you know of her. She's a wonderful trauma psychologist and researcher. Went to Adelphi University and got my PhD in clinical psychology, and also was in the TRACK program, which was a training program for underrepresented racial and ethnic minority scientists in the US. And then I moved back to sunny Charleston, South Carolina, and that's where I am now, where I work at MUSC, which is the Medical University of South Carolina, and that's Sudie back. So lots of moving because we move a lot in the States as well. Okay, so the 10,000-foot view, this is kind of where my wheelhouse is. So I focus on trauma and substance use and how individual identity or collective identity relates to both of those conditions. So we know that trauma, and most people know that there are so many different types of traumatic experiences and events someone can experience in their lifetime. And we also know that there are so many different types of substances people can use. But historically, any research or clinical work has been done separately from one another. And so these have been very much siloed areas of research and clinical investigation. And this is unfortunate because in most people's training, they see that trauma and substance use relate to one another, where trauma can lead to coping with substance use, and then substance use can increase the risk of trauma exposure, and it becomes this repetitive cycle. In the United States, the lifetime prevalence rate for PTSD is about 8%, which is probably lower than the actual rate. This is just based on our poor epidemiological surveys, which are not as good as Australian ones, in my opinion. And then the lifetime prevalence rate for substance use disorder is about 30%. 30 to 59% of people with a substance use disorder also have PTSD. So if you were to translate that into clinic numbers, if you have about 10 people that come into a clinic, up to 6 of them probably have PTSD that's being untreated or unaccepted. Okay. What's worse is that when both of these conditions co-occur as opposed to a singular disorder presenting, they have a more severe clinical presentation. So they have higher suicidal thoughts, behaviors, and attempts, a poorer overall quality of life, more comorbid depression and anxiety, and a poorer treatment prognosis as well. So overall, we're seeing a worse clinical picture when you have PTSD and a substance use disorder. So historically, and this is actually not even historically, in the US, this is how most medical systems still operate. If you come to a trauma treatment clinic and you say, hey, I went through this awful car accident, I'm having nightmares and flashbacks, I'd like to talk to somebody about it, they will do your intake and they'll say, oh, you're using cannabis 3 times a week. That's a huge problem, you can't be using that much. So they'll send you to the addiction treatment clinic down the road, and they say, please go there and become abstinent from using any cannabis, and then you can come back and we'll talk about the trauma that you experienced. Now, anyone who's a clinician knows that in reality, the likelihood of someone going to 2 clinics is very low, and 2, you've just taken away their coping strategy and give them nothing in replacement for that, and so now they have no way to cope with the trauma they experienced. So it was, although kind of made sense, it felt revolutionary, this idea of integrated treatment, so a one-stop shop where you could get both treatment for PTSD and a substance use disorder at the same place and at the same time. And when I was learning about integrated treatment, there were 2 that really stood out as being the best at the time. So one is Seeking Safety, which some of you may know and some people are probably trained in, which is a group-based treatment for trauma and substance use by Lisa Najovitz. And then the other one is COPE, Concurrent Treatment of PTSD and Substance Use Disorders Using Prolonged Exposure. It's always a mouthful. That was developed by Sudhi Back and colleagues. So these are 2 psychotherapies that attend to both trauma and substance use. But the key difference is that Seeking Safety is not trauma-focused. So you never talk about the trauma someone experienced in the actual therapy. You solely talk about how to cope with it and how to manage the symptoms, but not the actual events or experiences. Whereas COPE, you do something called imaginal exposure, where the individual, the client, will talk about the trauma with their therapist repeatedly, and thereby is trauma-focused. So COPE is designed by including 2 evidence-based interventions. One is prolonged exposure therapy for PTSD, and the second is relapse prevention. And this is COPE, and there's Sudhi, who's one of my lovely mentors and has facilitated me even coming to Australia today. So PE has 4 core components: psychoeducation on PTSD and what it is, imaginal exposure, which is repeatedly revisiting the traumatic experience and retelling it to your therapist in every session, in vivo exposure, which is doing homework activities in between therapy sessions where you have to approach things that are related to your trauma and which you may experience as fearful but are not actually fearful. So a good example is if you were raped in an alley, you may avoid all alleys. And so an in vivo exposure assignment that you would do with your therapist is to gradually start approaching alleys during the day when they might be safer so that you learn that they're not as unsafe as you used to know. And then the last part is trauma processing, so processing the themes that come up in the imaginal exposure and in vivo exposure to understand what you learned and what might be sort of distorted cognitions and beliefs as a result of your traumatic experiences. I'm going into this in grave detail because this will come up later on. So COPE, as is designed right now, consists of 12 90-minute individual sessions. You address trauma and substance use in every session. And there's about 3 to 5 hours of homework between sessions. It kind of depends on the motivation of your client. And in most clinical trials, we've seen about a 50% retention rate. So about half of the study sample will drop out. At the time that I was learning about COPE, it showed greater reductions in PTSD symptoms compared to all other treatments, greater retention in treatment, so even at 50%, it was showing the greatest retention, and equivalent to superior reductions in substance use compared to control conditions. So overall, COPE has been standing out as the best integrated treatment that we have right now. But I became very interested in opioid use because much of my graduate training was during the opioid epidemic that started in the United States. And I could see that one size doesn't fit us all. So the work that I do is really understanding these different permutations of comorbid conditions and how can we modify, personalize, and enhance treatments to attend to those unique presentations. So I always give this example. So this is a doctor in the United States. This was a New York Times investigation that was released who deliberately addicted his female clients to pain medications. And then when they didn't have the money to get additional prescription, would force them to have sex with him in exchange for future prescriptions. And so it just demonstrates the very unique relationship between opioid use and PTSD in these female clients that's different from, say, someone who had a military experience and then developed an alcohol use disorder. Okay, so let's talk about developing an integrated treatment for opioid use disorder and PTSD. So in the United States, this is somewhat dated now, but this is the opioid epidemic in 2022. So the New York Times in 2023 reported that drug overdoses now kill more than 100,000 Americans a year, which is more than vehicle crash and gun deaths combined. Given that we have so many firearms in the United States as well as mass shootings, it's kind of shocking to see that those values are still higher. 75% of drug overdose deaths are due to opioids, and South Carolina, which is where I live and work, shows a higher rate than most of the US. So in this map, you can see that the darker colors are higher levels of overdose death rates. And so West Virginia is what the WV is, and that's where there's lots of coal mining and there's lots of impoverished areas, and that's kind of the heart of the opioid epidemic in the United States. So what is unique about trauma and opioid use? Why should we focus on both of these conditions in particular? So this is actually an Australian twin study, and I love this study, so this is the perfect audience to present it to. But in this paper, they looked at 6,000 Australian twins, and one twin was exposed to childhood sexual abuse, and the other twin was not. And they wanted to see what were the associations between childhood sexual abuse and subsequent substance use disorders. And what they found is that the odds ratio, or the OR, was 6.50 for the twin that was exposed to childhood sexual abuse to develop an opioid use disorder in adulthood. What was interesting is that was the highest risk ratio of all other substance use disorders. So it shows a very unique relationship between childhood sexual abuse and specifically opioid use disorder. And what they hypothesize is because opioids have that numbing quality to them, they relieve emotional pain as well as physical pain, and maybe are sought out more for that sedative effect. Another study, and this was done by Tom Santo in 2021, did a meta-analysis of 62 different studies, about 22,000 individuals, and they found that across studies with opioid use disorder and childhood maltreatment, the highest rates of childhood maltreatment were in opioid use relative to all other substance use disorders. So again, highlighting that childhood trauma and childhood maltreatment are uniquely associated with opioid use in adulthood. And so you can see some of the rates there for childhood sexual abuse, physical abuse, emotional abuse, and neglect. And I'm just going to have you remember this later because we're going to talk about the definition of trauma later in the talk. And neglect and emotional abuse are things that we don't consider in the United States as criterion A traumas. Okay. So in the US, we have something called the NIH stage model. The NIH is the National Institutes of Health. Was our biggest funder and hopefully will still be our biggest funder. But in stage 1 is when you develop a behavioral therapy. Stage 2 is you do efficacy research on it in research settings. Stage 3 is doing it in community clinics and so on and so forth, you can see. Stage 5, which is the last one, is doing implementation and dissemination work. So knowing this model, I knew that COPE was the most effective integrated therapy that we have right now, but I wanted to figure out how could we modify it and adapt it to get to an efficacy stage for people with opioid use disorder and PTSD, given that people were telling us that they wanted a therapy for these two conditions. So the questions that inform the adaptation were, does COPE work as well for people with trauma exposure, PTSD, and opioid use disorder? Can it be combined with medications for opioid use disorder, so methadone, buprenorphine, and naltrexone? Can it be cut down to be more manageable for patients and providers? Specifically in the US, we don't have a reimbursement model for 90-minute sessions, except in Veterans Administration, which are military veterans and stuff like that can go to. So 60 minutes is the reimbursable rate with insurance. And then can we increase treatment retention given that we were still seeing 50% of people dropping out of COPE? Of the current COPE studies that we have, only 11 to 20% of the samples included somebody with an opioid use disorder. So it was a rare population or presentation in the studies. And none of them were taking a medication for an opioid use disorder, and all of them dropped out of the therapy before the end of the study. And so those were all indicators for us that we needed to modify COPE to enhance it for people with opioid use disorder and PTSD. So to do this work, I did 2 mixed methods, so qualitative and quantitative studies on women with opioid use disorder and PTSD, where we interviewed providers as well as patients with both conditions and asked them, what do you want? I won't go into the details today, but in short, we asked, do you even want your clients to get trauma treatment before we rush to provide it? Let's see if you want it. And then what would you want different in COPE so that it better fit the needs of your clients as well as your day-to-day clinical life? And all of that information is what led us to create HOPE, which stands for Helping Opioid Use Disorder and PTSD with Exposure. And I have to give credit to my amazing student who's done all of the graphics and logos for everything. So the largest themes that we got from those 2 mixed method studies was that providers wanted shorter sessions. They hated the 90-minute more than anything else. They wanted less homework. They wanted it to be augmented with medication so that it was therapy plus the medication for opioid use disorder. They wanted more distress tolerance skills in working with these clients, a modification to include for more traumas. So the way COPE and even prolonged exposure therapy are traditionally designed, you focus on the most traumatic event called the index trauma that the client is suffering from, but you rarely can squeeze in more than one trauma in the protocol as designed. More flexibility in the sessions, and that's because so many of the clients with opioid use disorder and PTSD have crises that come up, like they'll get unhoused or they lose their job, and it feels unfair to suddenly continue the protocol and not address the crisis. Safety planning, and then information on chronic pain as well as opioid use disorder itself. So we developed HOPE. It's for patients with opioid use disorder and PTSD that are stabilized on any medication for an opioid use disorder. Stabilized in this case means at least prescribed for 4 weeks, but they don't have to actually be taking it regularly. The design is 10 to 12 sessions, so they can end early if they want to, or they can go the full 12 sessions. It's 60 minutes of individual therapy a week, and they take their medication as prescribed by their prescriber. There's 3 key features, so there's much less homework. That was very clear early on in our pilot study, which I'll talk about, is that these individuals did not want to have to do homework every single day. Flexibility within fidelity is a model that we use, and this is kind of coming out of the PTSD literature first, but it's trying to bridge the gap between research trials and community settings, where so much of what we do in research trials doesn't mirror community settings, and what community providers tell us is how they work with their clients. So you have fidelity within the treatment module, but you're not required to do this in session 1, that in session 2. You can move it around within the overall treatment to provide more flexibility. And then the third feature is titrated exposures. So this is referring to the imaginal and in vivo exposures I mentioned, where you only have to do 3 per protocol of imaginal exposures. You don't have to do them every single session, which is how COPE and PE are designed. The theory, it's a very integrative approach, so it integrates cognitive behavioral therapy, harm reduction, humanistic principles, and psychodynamic theories as well. And then we also use something called the PrEP model, which are the 4 major mechanisms of the therapy: psychoeducation, relapse prevention, exposure, and processing. And this is somewhat of a busy slide, but it kind of shows you a snapshot of how it's designed. So in the module, which is on the left, you can see the components in the middle column of the skills that fall within each one, and then the amount of time in the overall therapy or treatment that you're in within each of these modules. And for exposure and processing at the bottom, you can see that it says a minimum of 3 sessions must focus on exposure and processing in the overall treatment. That's the way it's designed. Okay, so within the NIH stage model, we had done the mixed methods research to develop the HOPE protocol. Now we needed to take the car out for a test drive and see if it actually worked. So I was grateful to be awarded a National Institutes of Health or National Institute on Drug Abuse Career Development Award. It's a 5-year grant from the United States National Institutes of Health, and it gives you protected research time to do something. In this case, this is my something. So I did a pilot trial of HOPE among people with opioid use disorder and PTSD and taking medications for opioid use disorder. I should have mentioned these are the aims of the overall grant, and so we'd already done number 1, so we were moving to number 2. Okay, so this is the design of our open label pilot trial, which we published a couple months ago. And what we did is we said we would try out HOPE on 5 individuals. And we did an informed consent and baseline visit, which you can see at the beginning there on the left side. And then we saw them for 10 to 12 weeks. And then we did a 1-month follow-up visit. On the bottom of the slide are our assessment schedule. So the green arrows show our weekly assessments, where UDS is urine drug screen, TLFB is timeline follow-back, the PCL-5 is the PTSD checklist 5, and then the OCS is the opioid craving scale. And so we asked those participants each of those every week. And then at baseline, mid-treatment, end of treatment, and follow-up, we did the CAPS-5, which is a clinician interview for PTSD, and then the drug desire questionnaire as well. To be in this study, you had to have PTSD, you had an opioid use disorder, you had to be on a medication for opioid use disorder for at least 4 weeks, and then if you were taking psychotropic meds, stabilized for at least 4 weeks in the same dose. And I was actually the therapist. I was the study therapist of this trial because it was part of the training aims that I learned to deliver the therapy and work with the participants, and so I know all of them intimately very well. Okay, this is our consort diagram. It's probably pretty small for you guys to see, but essentially we ended up actually having 6 people in the study because we had 5 treatment completers and 1 person drop out. So we decided that we wanted to get 5 treatment completers, so we went up to 6. And we saw people both in telehealth and in person to kind of see if there was a preference also between those two modalities. So this is our sample. Most people were parents, and you can see most people also had an incarceration history. We had a breakdown about 60% who identified as female and 30% who identified as male. Not as diverse as we would like, but it was okay for the pilot trial. And then clinically, we were happy to see that we had all of the different types of medications for opioid use disorder represented. So most people were on buprenorphine or Suboxone. One was on Vivitrol and one was on methadone. It makes sense that more people with Suboxone would be seeking out care because another facet of the US healthcare system is that methadone is so highly regulated that you are required to come in every day in the beginning and get behavioral treatment, whereas Suboxone and buprenorphine don't have such high regulations, and so you can get the medicine, but you don't necessarily have to have any behavioral treatment combined with that. Most of our sample was a nicotine user, and actually I have a student doing a secondary analysis on that who has found some significant findings. And then there were on average 8 lifetime traumatic events most people had experienced. Okay, so what did we find? So we were happy to see that even on such a small sample, we had a significant decrease in PTSD symptoms throughout the treatment. There was a reduction by about 25 points, and this is the self-reported PTSD checklist 5, so where patients would write how much distress they had from PTSD symptoms, and that suggests clinically significant change for that measure. And you can see the red asterisks show that really started happening at session 4 and onward. The other thing that was exciting to see is that our decreases in PTSD symptoms mirror those of other trauma-exposed treatments like prolonged exposure therapy. So if anybody knows Kelly Peck's work, he has done prolonged exposure therapy in people with opioid use disorder and PTSD, and so that's doing the imaginal exposure every single session after session 4, and our findings were similar to his, and so it shows that you can reduce the number of exposures and still get the same gains clinically. A similar story emerges for the clinical interviews. So in our clinical interviews of PTSD symptoms, there was a significant decrease in PTSD scores from baseline to end of treatment and follow-up. I always think it's kind of interesting that it's only at end of treatment. It shows that by mid-treatment, people are still experiencing a lot of their PTSD symptoms, which is why it's even more important that people don't drop out around them because they haven't experienced that decrease yet. Unfortunately for opioid use, even though we did so many urine drug screens, there was no significant decrease in urine drug screens or the timeline follow back. But if you're a researcher, I hate the timeline follow back now, and so I have so many thoughts about that I can share. But this might be due to overall low use because everyone was on a medication for an opioid use disorder. Only 5 out of our 69 urine drug screens were positive for opioid use. So we had a very low positive rate, and there probably wasn't the power to detect it. And there was no significant decrease in other substance use from baseline to end of treatment or 1-month follow-up. But we think that's because of the way substances were measured. We saw clinically and anecdotally decreases in cannabis use or nicotine use or meth use, but the way we calculated it with the timeline follow back was by substance using days. And so even if someone went from 1 blunt to half a blunt, you can't capture that because the day is still coded as a substance using day. But one good thing is that we saw a decrease in the desire for opioids. So this is from the Desire for Drugs questionnaire. And what we saw is by follow-up, there was a significant decrease in opioid cravings, but only at 1-month follow-up. So it took some time for it to really show. It didn't happen during the therapy itself, which was a surprise for us. Okay, and then the biggest thing was the treatment retention. So 5 participants completed the entire therapy and follow-up. So 83.3% of people stayed in the entire study and treatment. It's the highest retention rate that we know of any trauma-focused therapy on people with opioid use disorder and PTSD, so we see it as a big win. And everyone was still taking their medication by end of treatment and follow-up. And people liked the therapy, which is important to assess. So we have people do the client satisfaction questionnaire after every therapy session where they really rated me on how much they liked the session. And the ceiling for this measure is a 32. And so you can see that from the beginning, it was already quite high. And then at the end, at session 12, it was almost at the ceiling of a 32. And it did significantly increase by the end of treatment. I always point out session 4 here because that's when you first have your client talk about the trauma with you. That's the imaginal exposure. And of course, they rated that session as lower. And so it just shows that even though we know imaginal and trauma-focused treatments is very effective, clients really struggle doing it. And so we can't bombard them to do it necessarily every session because it could increase dropout. And then these graphs just show that we saw a significant decrease in depression symptoms by end of treatment and 1-month follow-up, as well as in anxiety symptoms as well. I also just like to include some of the qualitative feedback of what patients said about the treatment. One client said the study was good, just need more treatment for futures and goals, so she actually wanted a longer protocol. Another said, I was sad for this to end, and it's been very helpful. He felt similarly. Learned a lot, now can conquer all fears and can fight them off without falling apart. And then the last one said, I think these therapy sessions were very helpful for me, talking about what happened and getting everything out. Feels very cleansing, and I always feel lighter after a session. It can be a little stressful before going into a session, but once I start talking, I feel more relaxed and ready to work on everything. The imaginals are particularly helpful, even though they are the hardest part. So our takeaways, HOPE shows preliminary feasibility and acceptability among clients with opioid use disorder and PTSD. We saw these within subject reductions in many clinical areas of PTSD symptoms, depression, anxiety, and opioid craving. But we still need to understand who HOPE is best for, if effects are better than a control condition, and then if it can improve substance use. So we are currently doing a randomized clinical trial, and I have to really thank my team who's keeping this trial running while I'm here, where we're trying to recruit 76 individuals, and we're going to randomize them to either the HOPE condition, which is augmented with the medication for opioid use disorder, or to a control condition where they just take the medication and they receive no therapy. This is the design. It's very similar to the pilot trial. We currently have 7 people enrolled in the study right now. And we did a 1.5 to 1 randomization scheme. And I'm sort of mad at myself for picking this in retrospect. You should have just committed 2 to 1 or 1 to 1 because the math is a little confusing. But essentially, it has more people going into the experimental condition of HOPE with the medication, and then less people going into the control condition since we know medications are so effective already. And the randomization is stratified by the type of medication they're on, their PTSD severity scores, as well as their opioid use disorder severity. And then that green line is like probably the biggest difference. We're also doing ecological momentary assessments while people are in the study across both conditions. So they get 2 texts, one earlier in the day and one later in the day. And the text will have 18 questions that ask them about their mood, their craving, their ability to cope, and their self-efficacy. So it's trying to see if people in the HOPE condition feel like they're more capable of coping with the symptoms they're experiencing, their PTSD symptoms, and any substance use. Okay, I think I'm going a little fast. Okay. So, 2 repeating systemic issues that kept coming up in HOPE, but I will confess that have kept coming up throughout my entire training and career thus far, is that there are traumas our participants would report that are outside the Diagnostic and Statistical Manual, or DSM-5, Criterion A definition for trauma. And so the DSM-5 is what we use instead of the ICD-11, and it's probably not as good, but we still use it. And so we kept having clients who would report things like imprisonment or incarceration was their worst trauma, or emotional abuse was their worst trauma, or emotional or physical neglect. And according to criterion A, none of these count as a traumatic event, and they don't rise to the level of being severe enough. And so we had to exclude them from the study or try to find some other trauma that they experienced that would be the one that would qualify for PTSD. And then the second issue we kept coming into is that our clinics could not identify the people who had opioid use disorder and PTSD. And so we kept asking this question of how can we even give people treatment if we don't have the screening tools or if we don't have the mechanisms to identify who even has these conditions in the clinics that we're working with. And so this led to 2 new projects. So with criterion A, the gap is very obvious. So this was a paper by Kean et al. In 2024. They did a meta-analysis of PTSD treatments. And what they found is that non-Caucasians across studies showed poor outcomes in trauma-focused treatments. I think there it is. So that's the exact effect size of that. But we know from other research that diverse individuals experience more trauma in their lifetime than non-diverse individuals. And this is especially true in the US. So the question is, why aren't trauma-focused treatments working better for minoritized individuals? Well, there's lots of reasons. So you guys have probably heard about the US in the news a little bit lately. But our socio-political context is not the best right now. And this is probably an outdated map in some ways. But in 2019, this group tracked 940 hate groups across the United States. And this number continues to increase every day. And the inequities that were exacerbated only within the 5 years have been because of the COVID-19 pandemic, ongoing police brutality, reawakened racial reckonings with the murder of George Floyd, climate change-related natural disasters, increasing incarceration, rising social inequality, global warfare, and of course, institutional racism. And so what we see in this map is from 2019 to 2023, there was a 52% increase in hate and anti-government groups. And that's just at a 4-year span. So it just demonstrates the context and the cultural experiences that are going on in the US that are exacerbating people's experiences of stress and trauma. So criterion A, this is just a picture from the DSM-5, is the definition for what qualifies as trauma exposure. You cannot get a PTSD diagnosis unless you have criterion A. And so you have to, as an assessor, always be kind of looking for the trauma that qualifies as traumatic enough to then get a PTSD diagnosis. Critiques of this definition include that it recognizes some individuals in societies. So specifically, it mentions police officers as well as healthcare providers, but then it doesn't recognize other individuals, such as people who are in prison or incarcerated, as well as immigrants. And so you can see that there's a bias of who it's trying to serve. So we have been thinking about this, some of us, for some time. And so we did a narrative review and a critical analysis of 3 salient trauma classes. And we tried to see, is there enough evidence to warrant their inclusion into criterion A? And the 3 classes were invisible traumas, identity-based traumas, and systemic traumas. And I always love this quote by Carl Sagan, that the absence of evidence is not evidence of absence itself, just as proof that you actually need to do the work to make sure that you have the evidence for what you want to exclude or include. So we wrote this paper, and we were happy that social science and medicine liked it. And it's called Are We Gatekeeping Trauma? A Conceptual Model to Expand Criterion A for Invisible, Identity-Based, and Systemic Traumas. And in it, we created this figure to kind of show what is the current range of assessment for criterion A and what's being missed. So what is it not capturing? So those white circles at the top show visible traumas and physical traumas. So it's biased towards things that you can really see in an individual, like physical assault or sexual assault or a car accident. Whereas at the bottom are the traumas that are invisible, systemic, and identity-based. And the ones that we highlighted in red here showed already enough evidence in the current literature to be included in criterion A. So psychological violence includes emotional abuse and verbal abuse. So there's several studies showing that people develop PTSD symptoms as a result. Violent media exposure, which is becoming more rampant, has been also associated with PTSD symptoms. Poverty, intergenerational trauma as two systemic traumas. And then for identity-based traumas, race-based trauma, so racial trauma is another term, and immigration-related trauma, both were rising to the level of criterion A. It's not to say that the other categories don't qualify as traumas, it's just that there's not as much evidence in the literature to date. So what would be the potential impact by expanding criterion A? So first, we could increase diagnosis and assessment. So we increase the detection and more accurate assessment of individuals who have traumatic experiences. We also could address this continuous discordance between what patients and assessors perceive as traumatic. So I can't tell you how many times I've done the CAPS and someone will tell me that their childhood trauma is the worst thing they experienced, and I have to ignore it and prioritize something like physical assault instead. In clinical practice, it would validate patient experiences, and we'd be more inclusive of diverse individual experiences. It is a good question to ask, who are our diagnostic frameworks for, and who are they serving? And it would decrease the need to qualify someone's trauma. So if someone experiences something traumatic, that we take that at face value instead of looking at it and being like, oh, is it really trauma? I don't know, and questioning them. In terms of research, I think it could expand research on the presentation of diverse traumas. And there are so many research silos within the trauma literature. There's people who do adverse childhood experiences work. There's people who do complex PTSD work. And then there's people who do PTSD work. And so if there was a way to see that we're all doing trauma research, if we can all just research it together and recognize the nuances within it, then it would unify that work as well. And then align better with the ICD-11, which you guys probably already know. Okay. And then the last big project I'll talk about today is this question of who gets screened. So this is an example of a notice of special interest that came out, I want to say a couple of years ago through the NIH, and it was looking for opioid use disorder care pathways for individuals with histories of exposure to violence. And we did a little bit of digging, my colleague and I, Dr. Jarnicki, and we found that 90% of patients receiving methadone treatment reported experiences of intimate partner violence. Opioid use is significantly associated with the perpetration of violence. Opioids are often sought out after experiencing intimate partner violence because, of course, they relieve physical pain as well as the emotional pain. But also that can then lead to future intimate partner violence. So again, that cyclical trauma and substance use cycle happens here as well. Of the existing screening tools in the US, they only screened individuals who are female presenting, and so males are never screened for when it comes to intimate partner violence in any opioid treatment setting or any substance use treatment setting that exists. And so we wanted to increase screening of IPV. So there's me, pre-pregnant, and Amber Jarnicki. So we created the iPivot toolkit, which we're actively doing now. We got this grant a year ago. And what we proposed is that where we live, South Carolina, has consistently ranked in the top 10 states for intimate partner violence in the US. And that's partially due to the access of firearms, which is estimated to increase homicide by IPV by 1,000%. And so a lot of people are dying from IPV that uses a firearm as well. So we wanted to see if we could develop and implement a digital toolkit to assess for intimate partner violence and its correlates in opioid treatment programs within the state. And the real goal was to increase linkage between domestic violence shelters that exist in the state and then opioid treatment programs so that they could work together and help people get some safety and care. So the way that we decided to do that is we proposed to leverage technology and dissemination implementation science. The yellow is where we are now, so we're in the very beginning stages of developing the toolkit, and we're first interviewing stakeholders. That includes opioid treatment providers, intimate partner violence specialists, and IPV survivors themselves. And we're developing a community advisory board, which consists of state leaders and local leaders who have expertise in both of these areas to get their feedback on the design of the toolkit. And this was my proposal for the algorithm in the grant. But you can see the black box is where you start the digital toolkit. An assessor at the clinic would give you this, and then you'd be prompted throughout the toolkit on questions and assessments. So if you're in a current relationship, you'd be assessed for intimate partner violence. then you'd be assessed for danger, and then depending on your score, it will give a different output for the intake coordinator or the provider to have a conversation with you on if you want to leave the relationship, how to develop a safety plan, and what are things that are warning signs that you might need to leave. So this is the very early stages of our toolkit. That's what it looks like, and that's what people would see on an iPad. And the hope is that it can screen, safety plan, and provide treatment and referral recommendations for not only intimate partner violence, but associated mental health conditions of depression, anxiety, suicidality, and PTSD. And so we're hoping that this increases IPV screening, people who screen positive for IPV detection, recommendations and referrals, and also helps people stay on their medications as well if they're taking any. Okay, so I covered how did I get here, the passion, the intervention, the issue, and the toolkit. So where am I going next besides Australia? So I'm hoping to move into stage 2. So I'm submitting an R01, which is sort of a large grant proposal to the NIH to assess HOPE further after this RCT that we're doing right now, and to look at mechanisms and implementation factors so we could try to implement it into community clinics in the United States. We have iPivot that's ongoing, and we have some ongoing work on racial trauma and how it relates to opioid use in Black and African Americans in the United States. And then I'm due in November, so have a baby and learn how to become a parent are also on the list as well. Okay, and this is how you can contact me. And before this baby, this is my plumeria, which I've learned is called frangipani. But this is my baby at home right now. Thank you.
Thank you so much for that fantastic talk, Tanya, and it's such a pleasure to have you here. We've got some questions that have come through in the Q&A. If you were hoping to submit a question online, please pop that through. Also for attendees in the room, we'll probably take a couple of questions from the room as well. If anyone has a question, just put your hand up and sort of walk over. So Tanya, if you want to join me on the screen, one of the questions we had come through was, you commented a little bit about opioid use disorder and substance use sort of trajectories and PTSD. There was a question around ADHD specifically, and if you wanted to comment on ADHD and also sort of like neurodivergence in relation to PTSD.
Yes, that's a great question. So one of the criteria for PTSD is like concentration difficulty, so we somewhat capture that. But it's actually been something we've been grappling with because so many of our clients report that they have ADHD or are taking medication for ADHD, which of course shows up in every urine drug screen. So we haven't like directly addressed it in the intervention, but I do think that it's quite common in the comorbidity at this presentation as well. So I hope that answers their question.
Another question, again, thinking about your adaptation of COPE into HOPE and thinking about other sort of trauma processing interventions, there was a question specifically about the trauma processing framework that's in COPE and then relationship maybe or comparison to CPT. If there's any thoughts about that,
Yeah, I think that's a really good question. So CPT is cognitive processing therapy, if anyone doesn't know what it is. I do think that HOPE is a little bit more like CPT in that way, in that the processing focuses on themes like power and control and abandonment, whereas in COPE, how it's designed, it can be a little bit broad and is really more focused on the trauma itself. And so I think it leans a little bit more towards CPT in that way. So that's a good point.
That's really helpful. I might just see if there's anyone in the room who has any questions at all for Tanya. Really quiet. We might just take one more question from online before we wrap up. I think one of the questions that kind of came through was around the power threat meaning framework. So I'm just going to test whether this is something that's familiar to you before I ask this question. So this is a question that's come up from an attendee. I'm not sure where they are, but perhaps they've read sort of the British Psychological Society's kind of framework around this. And I suppose it's a slightly different sort of framing of trauma and PTSD as a whole. So it's a really interesting kind of framework, I suppose, and interesting to kind of think about some of the work that you're doing, the conceptualization of trauma, the criterion work that you're talking about in terms of gatekeeping. I guess a question for us and some of the Australian clinical audiences around that sort of gatekeeping concept. Did you have further thoughts on how to kind of expand that concept beyond that narrative review that you talked about?
I think we have to change our, well, so I don't know the framework, but I think we have to change the DSM-5 criterion A definition so that it doesn't prevent people with other types of traumas being included in the understanding of PTSD, because so much of the reliance on PTSD and I think there's almost like an obsession with PTSD because it's like, oh, it's not you. You can blame the trauma as what happened to you, whereas other mental health conditions, there's a little bit more stigma and blame, I think, than with PTSD. So some people actually say that we should get rid of criterion A completely and that PTSD should just be a symptom diagnosis, that we shouldn't have any qualifying event that warrants inclusion. And I think that actually might be a good idea to get rid of it completely so that it can just be the symptoms as they present.
It's a really interesting thought and somewhere a good place to end this discussion. Lots of thought-provoking content from Tanya. So just get the audience to kind of thank you for your presentation and we'll wrap up there. Thank you very much.